Hello, and welcome to today's Patient Engagement HIT.com webcast sponsored by LexisNexis Risk Solutions Healthcare. Three ways to success with just social determinants data: motivation, myths, and management. I'm Lindsay Carlson, Vice President at Extelligent Healthcare Media and moderator of today's webcast. We will begin with a presentation by our speakers and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of their screens. The presentation deck is available for download under Resources on the left-hand side of your screen. For all technical matters or difficulties, please click the Help icon at the bottom of the screen. A recording of the webcast will be made available following this presentation. First, I'd like to thank our sponsor, LexisNexis Risk Solutions Healthcare. LexisNexis Risk Solutions Healthcare has mastered the art of combining, analyzing, and delivering data and analytics to optimize quality, performance, and impact across healthcare entities. Our solutions leverage the industry's most robust and accurate provider data, comprehensive public records, proprietary linking and claims analytics, predictive science, and computing platform to transform the business of healthcare. With that, I'd like to introduce our speakers, Rich Marino, Director of Strategic Solutions, and Aaron Benson, Director of Market Planning at LexisNexis Risk Solutions Healthcare. Rich is part of LexisNexis Risk Solutions Healthcare's strategic clients team. In his current role, he provides industry and solution expertise on such topics as improving health outcomes, reducing the cost of care, and enabling consumerism. Over the past 20 years, Rich has focused on the use of analytics and predictive modeling on healthcare and non-healthcare data. Rich has leveraged his background in industries such as benefit management, statistical software, FWA, and HIT. Rich has worked at such companies as Optum, then Ingenix, SAS Institute, and Change Healthcare, then MDON, in roles ranging from industry consultant to sales management. Rich is a graduate of the University of Illinois. Aaron serves LexisNexis Risk Solutions Healthcare as Director of Market Planning. Her focus is on the development and execution of strategic planning for member identity and socioeconomic determinants of health solutions. Prior to joining LexisNexis, Ms. Benson was Senior Consultant at Deloitte Consulting. She holds a bachelor's and master's degree in Human and Organizational Development from Vanderbilt University and an MBA in Strategy and Management from Duke University. Rich, I'll now hand the floor over to you.
Well, thank you for that introduction, and thank you for all of you online who are attending this webinar, or those of you who may listen to it via recording. The three objectives listed here are what we hope you walk away with at the conclusion of our time today. And throughout our presentation, we're going to go into more detail, but to summarize, social determinants of health has tremendous potential to positively impact the health of our patients. And the data required to identify those at risk and why they may be at risk, which is additional critical insight, should be treated just like clinical data, with all the requirements for ethical use. So we'll spend a few minutes of our time today going over that. We'll also discuss the initiatives that utilize social determinants of health data and the requirement for broad insight, or the requirement of broad insight into our patient's socioeconomic and economic status. We'll discuss what type of data is required to gain that insight. And finally, we're to discuss the tremendous amount of buzz on our industry in regards to social determinants of health. Enough so now that there's practically as many myths about the use and effectiveness about it as there are accurate information. So we're going to spend some time peeling back those myths and help shining a light on where it does provide true value for our operations. So with those objectives in mind, let's go ahead and get started and move right into motivation, as in why should an organization take on social determinants of health initiatives? There are five most commonly agreed upon categories of social determinants of health. The fifth category is access to healthcare, which we really won't focus on during today's webinar, as you all actually represent that fifth category. However, if you have questions about this, feel free to go ahead and log them in now or ask us at the end of the webinar, and we'd be happy to provide you additional insight into that fifth category. Imagine, if you will, as you look at this slide, though, that you're a clinical care coordinator, and you know that your particular patient might have COPD. How valuable would it be to you to understand or know the education level of the individual you're working with, or their health literacy, and how would that change how you're trying to engage and communicate with them? Or whether that patient suffered from address instability or potential homelessness. Would that change perhaps how you engage them and what you might prescribe to improve their health outcomes. Or finally, as long as we're talking about these scenarios, let's just assume that they live in a high crime neighborhood without access to parks and bike paths, which also likely is a food desert. Knowing that they can't get out and exercise and their access to nutrients beyond pre-processed foods likely isn't there, what insight does that give you as you're trying to go ahead and improve this person's health status? The answers to these questions are what we call the X factor, which are needed to achieve optimal health. And that's really what we're going to go into today. So with that knowledge, that brings us to our first poll of the day. If you guys could go ahead and answer this question for us, we'll show you in real time some of the results. The first question is, do you currently tailor care management and patient outreach based on socioeconomic information? So if you could click, we don't do this at this time. We use patient-reported health assessment information to at least get us started. We source data from a third party to engage with patients based on this information or other. And in a minute, we'll go ahead and review some of these poll question results. Okay, let's go ahead and see what the results of this poll are. So the majority of you are dabbling in social determinants of health and you're utilizing it through patient-reported health assessment to at least get us started. Well, the second largest category doing we don't use this at this time. So hopefully for both of you, the insights that we're going to deliver here will allow you to go ahead and tailor the programs for those of you who've already started. And for those who are looking to possibly evaluate the potential use of social determinants of health, can gain insight and leverage the wisdom of the efforts that have already been started. So let's go ahead and continue with our topic of the day. We're getting into motivation. Gaining insight into your patients and acting upon it requires a new way of thinking and acting. And so you might ask yourself, why would I want to take on this project given that it's required changing the way I do things today? The answer is on the statistics in this particular page. First, social factors alone account for only 33% of total deaths. Social, economic, and environmental factors determine 50% of overall health. At least 25% of our healthcare spend is on diseases or disabilities that result from potentially changeable behaviors. Patients less actively involved in their own healthcare have 8 to 21% higher costs than more actively involved patients. And finally, patients are nearly twice as likely to be readmitted in the next 30 days if they're less actively involved in their own care. These are statistics that are near and dear to us as we're being measured on how we make an impact on our patients. So if your objective is to improve health outcomes, and especially if you participate in any clinical quality programs, this information is crucial to your ability to manage health and health outcomes. Let's take a look right now at the story of Larry and Bill. Statistics are interesting, but when we actually look at two people, it paints a clearer picture. Before you look at Larry, or as you look at Larry and Bill, basically what you see is an example of two people who look very clinically similar. They're roughly the same age, have the same clinical condition. Let's say they have COPD and they might be pre-diabetic. And they both live in a rural setting. So based on our clinical information, we would likely treat these two the same. But as you see Bill and Larry, and you look around them in those bubbles, what you're seeing are those 5 categories of social determinants of health. So let's supplement our clinical understanding of Larry and Bill with the social determinants of health information and see if that changes the way we would evaluate treating them. While they looked clinically similar, their social determinants of health paint a vastly different picture. Now, unfortunately for Larry, he does not live near any hospitals or primary care physicians, so potentially may put off or avoid preventative health altogether. He's averaged less than $25,000 in income the last 2 years, meaning that medication adherence may be a challenge due to affordability. He has no education beyond high school, which may lead to issues with health literacy and communicating at the right level. He also, we can see, is socially isolated, with no relatives or close associates nearby who can act as caregivers or simply nag him into compliance. And then finally, he lives in a high crime neighborhood, meaning that any suggestions to get out and exercise will likely not occur without someone probably arranging transportation for him to maybe a township center or a safe park where he could go ahead and get that exercise in. Now let's compare that profile of Larry to Bill, who also has COPD, maybe pre-diabetic, same age, and lives in a rural environment. Bill lives near healthcare facilities and physicians, so gaining access to health is not going to be a problem for him. He has steady and high income, so affording prescribed care is less likely to be a problem. Bill has a master's degree, and every member of his family has at least a 4-year degree, so health literacy and communication will likely not be an issue. He lives with a spouse and has relatives within 10 miles, so Bill has a network to help him with his health care. And finally, he lives in a safe neighborhood, so getting out to go for a jog or a brisk walk is something that isn't too onerous to ask of Bill. With this new and enhanced view of Larry and Bill, we now know our approaches to managing their health should be very different. Bill could be coordinated likely with emails to participate in wellness programs or reminders to attend screenings and treatments. Larry, well, we'll likely need to see what benefits he has beyond simply health. Was he in the military, and perhaps we could take advantage of benefits there? Is he on Medicaid? And if he's on Medicaid, can we move him from TANF to SSI? So there are more resources available for us to potentially move him out of his dangerous living situation now if we truly want to go ahead and impact his health care. That gets us back to our conversation about the ethical use of information and social determinants of health. As you looked at those 5 categories and saw information, you saw information which might be deemed personal. Really, this is the type of information we need to understand whether or not someone might be at risk beyond their clinical information. However, the way we use this information, even though it is non-clinical, really should be treated with the same privacy and ethical considerations that we would with our clinical information, which constitutes personal health information. In order to get the message out to the public, eHealth sponsored a collaborative project to outline the healthcare industry and what the appropriate and ethical uses of social determinants of health data are. Now, this collaboration included not only technology vendors such as ourselves, but a broad swath of healthcare stakeholders such as AHIMA, AHIP from the insurance side, EMR vendors, life sciences companies, teaching hospitals, and health insurers. And right here, this list of 5 categories was the stake in the ground that the collaboration put together and said, if you're trying to make an impact on health, if you want to use social determinants of health information, which is of personal nature, this is the appropriate uses for it. Because just like evaluating clinical data, this can be used to improve health outcomes and should be used for these 5 purposes alone: care coordination, recognizing health and wellness risks, mapping community resources, identifying gaps. So which social services are available in certain communities for people who are, for instance, homeless or lacking transportation or live in a food desert. Understanding the service and impacting the service impact and assessing which programs are working, and customizing health services and interventions to individuals and patients based on their social determinants of health situation. So to sum on up, as we look to utilize social determinants of health information, we should view this information with the same care and rigor that we do clinical information. It's important that we do this because this slide shows and demonstrates to us our patients expect this of us. Overwhelmingly, you could see consumers want more collaboration between their community and their providers, payers, and employers. So the top bucket shows us how much collaboration or what percentage of the patient population views collaboration between the doctor and hospital social services to be important. Right there, same thing with insurance companies and even their employers for those of them who have private insurance to their employer base. So it's not that our patients are sitting there and screaming for silos of information that can't interact. Conversely, they want appropriate use of this information, and they want it to be collaborated with so that ultimately it will improve their health care. So momentum is gaining. This brings us to our next polling question. Which of the uses are most critical to your organization? Care coordination, recognizing risk through social determinants of health analytics, mapping community resources and identifying gaps, service and impact assessment, so assessing the services and the impact they made on health outcomes, and finally, customizing health services and interventions based on specific social determinants of health identified needs at the patient level. We'll take a minute here and let you fill this in so we can see the responses. All right, let's hope that most of you got your answers on in. We're going to go ahead and click and see what the initial analysis shows us. So recognizing risk through social determinants of health analytics is seen as the most, I'm going to take that back. Lo and behold, down the bottom, I missed that. Customizing health services and intervention. 1/3 of you chose that bucket, meaning that if you have this insight, the ability to go ahead and tailor the clinical care program and the services that it should provide would be the number one largest benefit to your organization. That is followed by recognizing risk. And we see that a lot within the industry. There's initially a large focus was on identifying those at risk, and then it started to be, why are they at risk? And you need to understand that why in order for the bottom right here to customize health services and interventions. So on to this knowledge, let's move on in and start attacking the myths. What is true out there versus what is noise in the system? So we're going to start talking a little bit historically, then we'll get into today. Historically, when people or organizations entertained social determinants of health initiatives, they went ahead and took a look at basically what data can I get a hold of which might give me insight. And their first attempt at this was basically census level or census informed type information. And if you think back to that slide where I showed you 4 of the 5 categories of social determinants of health information, really what this information did was provide insight on the neighborhood and built environment category with very little information beyond that. So it was able to provide insights like, for instance, perhaps how many people and what the relative wealth was of the neighborhood that you lived in. So that was a good start, but it also was rife with problems. First of all, it doesn't cover the other categories of social determinants of health. It really takes a leap of faith to believe that based on a zip code and general information, you can really assess a person's financial stability or their social engagement or their access to transportation, so on and so forth. And frankly, we often fell into the problem of trying to make that assumption and learning that we got it wrong. So let's take, for instance, that your patient lives in a gentrifying neighborhood in an urban environment. It could very well be that there's more Section 8 housing in that neighborhood, in that urban location than anywhere else. And based on that, the median income for that neighborhood is quite low. It might appear that they live in a food desert because of the lack of nutrition and the income level. We make that correlation. But it might also be that that neighborhood is going up and gentrifying quickly, and that right next to Section 8 housing, your particular patient lives in a luxury condo, drives a high-end and expensive SUV, and can drive themselves to a Whole Foods where they can buy overpriced produce that gives them the nutrition they need to overcome the fact that they live in a food desert. So the first generation it provided some initial insight that it wasn't reliable for the efforts that we've outlined already. The second level or second generation attempts was really kind of a large leap forward, and that we tried to avoid looking at general assumptions based on where you live and trying to gain access to information at the actual patient level. So we went to basically the first organizations that we understood, and largely these were the bureaus or marketing companies. And again, there was some insight to be gained. If you go to a bureau, you might be able to understand the person's creditworthiness and their overall economic condition, but with little insight is gained into the other 4 categories of social determinants of health. Marketing data, likewise, if someone subscribes to a fitness magazine, does that mean that they are fit? Does that mean that they aspire to be fit? Or does that mean that they're horribly unfit and this is their relative's way of informing them, get with it? There was also a problem larger than those that this data was never designed for social determinants of health use. In essence, it's simply the vendors providing all the data they have on your individuals with the hope that your team might be able to go ahead and sort the wheat through the chaff and understand which pieces might be useful. This led to a horrible amount of lag between getting the data and finally getting to the point where you gain insight. So a next generation capability was required that addresses all those categories of social determinants of health and provide quicker time or decreasing time to value while providing a lift in the actual accuracy of information. And that's where we are today. You need sources or a source that can cover all 5 categories of social determinants of health data. And you can see right here that encompasses the economic stability, education, health and healthcare, neighborhood and built environment, and social community context. And we need this at the patient level. It does no good. We looked at Bill and Larry earlier, and Bill and Larry both lived in a rural environment, and so we would make assumptions based on them that they seem the same, but we could see at patient level data there's vast differences between the two of them. And this is the final point, which is very much a stake in the ground that us and others have tried to articulate. Data dumps aren't that useful because all that means is we're taking the work of making sure this data can help inform us of health risk, and we're dumping it on you and your analytic team who already has a large amount of work to do. So every piece of data that should be sent out as part of a social determinants of health package should have already been proven to correlate some form of health risk, whether that's on hospitalization, ER utilization, pharmacy costs, etc. The data that comes to you should already be ready to be tested, tuned, and deployed to provide you a decreasing time to value and an increased lift and insight on your patient population. And that brings us to some of the most common myths out there. Erin, I'm going to let you address these.
Great. Thanks, Rich. I appreciate you providing the overview of the evolution of social determinants of health and what's required to glean meaningful insights. This is a really important area, so having observed the healthcare market's evolving efforts to incorporate social determinants of health into workflow, we want to elaborate on this a little bit more by discussing 7 myths and truths about social determinants of health data. If you've attended our webinars before, a few of these are going to sound familiar, but we've identified some new ones too as the industry continues to evolve. The first myth is that socioeconomic data is just more noise in an already data overloaded world. You heard Rich discuss the dangers of just doing a data dump of, what might be socio data and how important it is to look for that clinically validated data. And the truth is, socio data, when it truly is clinically validated and associated with health risks, is incredibly important. The National Quality Forum, the CDC, and the World Health Organization have all acknowledged the impact and importance of addressing social determinants. And studies from county health rankings have shown that medical care determines only about 20% of overall health, while social, economic, and environmental factors determine 50% or more of overall health. So to effectively achieve those better health outcomes for patients, providers really can't afford to ignore half of what determines their patients' overall health. In addition to being very valuable data, socio data can actually make patient risk assessment more efficient and less time-consuming. So, for example, it can eliminate the need for many of the survey questions and subsequent manual entries that are currently used, which saves staff time and decreases the risk of manual entry errors. The data can also be integrated into EHR and population health systems for easy access and making decisions about care. For hospital systems that are concerned about overwhelming their physicians, other medical staff, social workers, or even newly created positions like health coaches can help assist patients with getting access to community resources instead. The second myth is that all data about a person outside of their medical data relates to their social determinants of health. As Rich mentioned, while this data may be useful in some capacity, not all data is a social determinant of health. One of the clearest examples of this is that we've seen some providers gravitate towards marketing data because they may already have access to it in their systems. However, that marketing data is designed to improve messaging during campaign outreach, but its purpose really isn't to improve health outcomes, target care interventions, and enhance predictive models. Our data statisticians performed a comparison analysis and found that true socio data was almost as much as 17% more accurate in predicting health outcomes than marketing data alone. Clinically validating those attributes against actual health outcomes becomes critical to successful predictive analytics because some attributes just don't correlate strongly to health outcomes. In fact, in an analysis our data team did, they looked at 560 attributes and narrowed that down to only 442 that they found to correlate with key health outcomes like readmission, medication adherence, hospitalizations, and overall health costs. Even when those attributes are clinically validated, we know different attributes correlate to different outcomes with different accuracy strengths. So, for example, it's commonly understood that the likelihood of being readmitted to the hospital after a discharge increases with age. But what's less known is that you're less likely to be admitted to the hospital if you have a higher average property value than other individuals your same age. Knowing these types of correlations can help determine which data enhances predictive power so we can improve risk stratification efforts. The third myth is that examining only individual socioeconomic attributes about a person will allow you to make accurate predictions about their overall health risk. The truth is that if you look at only individual attributes rather than in the combined picture, it's very misleading. It would be like eating the individual ingredients of a cake and expecting them to taste like the cake itself. The results are very different. So in predicting risk and personalizing care management, it's important to view a person holistically across the multiple categories of social determinants that Rich mentioned, ranging from social and community context to economic stability and education to neighborhood and built environment. Any attribute on its own isn't enough to develop an accurate risk understanding, but by combining those relevant attributes, a more complete picture emerges. For example, low income often correlates with poorer health outcomes, but the additional knowledge that that patient is in college may indicate that the low income is temporary. The patient may actually be more likely to attain a better health outcome since education often leads to better career opportunities and a higher future income. The fourth of our 7 myths is one that I continue to hear and one that Rich mentioned before, which is that aggregated data at the zip code or census level can be used to personalize care for a patient. While that data can be useful for market expansion and resource allocation decisions, it's not the best use for personalizing patient care. For that, you want to look at the hundreds of attributes in order to determine an individual's health risk. As Rich mentioned, within a single zip code, it's not unusual to see variance in income levels, crime rates, and other factors impacting an individual's neighborhood and built environment. And just like his gentrification example, you could walk a few blocks and start to see very different social determinants of health. So that's why it's important to look at an individual's specific address and then also look at the influences of education, economic stability, and social and community context. Getting data across various categories of social determinants at the individual patient level allows care providers to see a more comprehensive view of a patient and create a more comprehensive plan of care outreach. The fifth myth is that social determinants of health data is only useful if it's combined with clinical data. While it's true that adding socio data to clinical data can help providers to personalize care and more accurately predict risk, even in the absence of clinical data, using only socio data has proven to be useful. It can more accurately predict risk based on total cost than traditional age and gender predictions alone, and it's shown to be as and sometimes more accurate at predicting readmission likelihoods in certain clinical data models. Outside of risk prediction, social determinants data informs care plans in ways that clinical data can't by pointing out the barriers each individual may face to following care recommendations. It's important that care plans include recommendations that are affordable, easily accessible, and easy to understand so that patients will be able to follow those recommendations. The sixth myth is a new one that I've seen emerging, which is that addressing social determinants of health is just too expensive for healthcare organizations. The reality is that the United States already spends more on healthcare than any other country in the world, and it hasn't done a lot to improve our life expectancy. A key difference between the U.S. and many countries is that we've not historically focused on care outside of medical care. This means that addressing social determinants is a critical key to lowering the overall healthcare spending. It's true that value-based care requires an enhanced approach to delivering care, one that focuses holistically on patient health and outcomes rather than volume of services rendered. And as I referenced previously, organizations may need to hire additional staff such as health coaches or train existing staff to provide patient education and support, as well as connect patients with community resources that address social determinants. They may also need to provide funding to some of these community resources to support their efforts, such as providing funds to stock food pantries. However, these costs to address social determinants can ultimately help providers maximize reimbursements and minimize penalties under value-based care initiatives like MACRA by improving the health outcomes of their patients. For example, connecting patients with ride-sharing programs so they can make it to their follow-up appointments may prevent much more costly hospital readmissions. The last myth we want to discuss today is that patients' behaviors have a bigger impact on their overall health than social determinants. The truth is that studies have shown that socioeconomic factors contribute more to health outcomes than behavioral factors do. And it makes sense when you think about it because social determinants often answer the why behind the behaviors. So for example, we know that exercising is an important behavioral determinant of health. So why is it that an obese patient doesn't exercise? That's where social determinants can offer an explanation. If they live in a high crime area, it might be unsafe to exercise outside. If they have financial challenges, they may choose paying utility bills over a gym membership. If they don't have a strong social support system, they may not be motivated to get healthier. The behaviors are strongly influenced by circumstances, and by addressing social determinants of health, providers enable those better health outcomes. Now that we've discussed some of the myths and realities associated with social determinants of health data, I'm going to turn it back over to Rich to talk about how to manage and make the most use of those insights.
Thanks, Erin. So let's launch into management. How have people historically brought social determinants of health projects to light, and what lessons can we learn as we deploy from a brand new perspective? Right now, you're looking at a slide that says turning potential into value, where we've been. So the first efforts that utilize in social determinants of health information really follow this model. Health system would get the information, and they do a health risk stratification on the patient level. They would do this sometimes by combining clinical information with social determinants of health information, or do it on social determinants of health information alone. And that oftentimes depends on the target that you're trying to predict. Are you trying to predict readmission, low-intensity ER utilization? Are you trying to impact or predict motivation? Every single target has a different answer in regards to what type of data should I source and which attributes make the most impact in this particular prediction. That was the first level they did, and it was amount to a little bit of boiling the ocean. We took a look at your entire population health, population's health, and we stratified those in your classic 5 segments of health risk. The next section we tried to do is understand the social determinant of health barrier that may be driving that risk. So as Erin just alluded to, let's say that you have diabetes, and the underlying thing that is driving your risk might be that you're socially isolated and lacking transportation and live in a dangerous neighborhood. So if we want to get you to exercise and to follow up your insulin, we probably need to find a way to either get you to the insulin or get the insulin to you and get you out of your house to a place where it's appropriate for you to go ahead and exercise. Then we needed to go ahead and crosswalk the two and present that to care management. So in all those people that we ran, the ones that represented the most risk or the actionable risk, and the ones we had to take a look at that, who represented the actionable risk, and then we had to compare that to what is the predominant health barrier or barriers that was driving that risk. And then finally, in bucket 3, is there a social service that we provide today or that we could align with which could address that? Now, I will tell you that there's lots of organizations that had success with this model, and there's nothing wrong with this model. However, this is a long-term solution that sometimes our organizations need to show some short-term wins. So we've taken, I shouldn't say that, we've seen a change in behavior in the last year and a half to a new strategy which we found provides a lot more wins by utilizing social determinant health insights while building out that larger population health strategy. And it looks like this: delivering ROI through projects while building out population health. So the first step, and I'm borrowing this metaphor from other industries, is let's think globally. Let's segment your entire population, identify the frequency and density of health barriers, right? And what I mean by that is, let's say, for instance, that you service a 5-county area. Within each of those counties, and specifically oftentimes within the population centers where your patients reside, what are their clinical problems? What are their social determinants of health problems, those barriers? And is there a solution that we could go ahead and address? This is exactly the strategy we saw on the previous slide. Where things change is the next two steps. It's great to think globally and build up that long-term play, but let's act locally and get some short-term wins. Let's model specifically for the at-risk patients who have health barriers where you already have programs in place. Now, I've seen all sorts of press releases, for instance, about some health systems who are providing non-emergency transportation, as many as 50 a day, to folks who are coming in for screenings or for treatments or for lab results and tests. Other health systems are out there working and providing housing certificates because they recognize that if they identify that someone is housing unstable, they are likely to have 4 to 5 times the cost in medical expense than folks who are in stable housing situations. So I'm not advocating you should do one of these two, but what we've seen successful is where you already have a social service in place, let's reverse engineer and find that health barrier amongst your population who's at risk. And let's align those people with that service, taking advantage of existing plumbing that you already have in place. The metaphor I like to use is let's build a house from scratch, how we'd like to have it done, with the idea that that might take a year because it's a new subdivision and nothing is hooked up. We still need to get the city water and the sewer and the utilities on out there. We're designing that system and building it to be the home of our future. And then right now, though, we're to buy a home that already exists. It is already hooked up, all the piping, the water, the utilities are hooked up. We just need to turn it on and increase the flow between the services and that house. And the last one we could do, take advantage of that existing piping to that existing house, is a focus on quality scores. So social determinants of health can have a huge impact on such measures as 30-day readmission, colorectal cancer screening, and medication reconciliation post-discharge. Informing us of who these people are at risk and why allow us to take preventative measures which will A, improve their health outcomes, and B, reward us in the form of improved clinical quality scores, which could benefit us in a variety of ways. I'm going to spend a slide talking about that. On the left-hand side of the screen, you see probably the world you live in. There's a lot of clinical quality measures and alternative contracts we have to navigate. MIPS and MACRA obviously is very important to us. The hospital readmission reproduction program, try and say that one slowly so I don't, what happens if you try and say that 5 times and fast. Then we move on to the next generation ACOs, followed by commercial ACOs, which we hope are loosely based on what Medicare is doing, but not always actually what occurs. And then finally, there's requirements on health systems from our health insurance brethren who need to collect their own information from us for their HEDIS and STAR programs that they participate in. So there's a large swath of measures out there that we are being held accountable to. To the right is a few of them, just to be illustrative. I've taken some of them from the MIPS, and you can see right here colorectal cancer screening, breast cancer screening, medication reconciliation post-discharge, and 30-day all-cause readmit rate, in this particular case for discharged inpatients. And what I show to the right is the key insight required. So for colorectal cancer screening and breast cancer screening, breast cancer screening women between the age of 50 and 74, we've shown some history in the past, right? What we probably need to improve our measures is to understand who is likely to come in on their own, who is highly motivated to participate in managing their care, who is moderately motivated, and who is highly unmotivated. And for a clinical quality program, we probably want to target the people to moderate to bordering on high, but not extremely high risk. We want to understand why. Why are these at risk? Why are these people at risk? Is there something that we could do, especially if they're at moderate risk, that if we remove that barrier, we'd get them to attend their screening, allowing us to find out well ahead of time before something advances that there's a problem we can tend to, as well as allow us to gain the benefit of demonstrating we met that clinical quality measure. So there's the capacity to utilize motivation and a motivation score that you could acquire, or a motivation model that you could build, combining socioeconomic as well as clinical information. But also for medication reconciliation post-discharge, you could do the same thing with a medication adherence score or model. Typically, most of the people that we work with trying to find medication adherence is someone who is likely to have 80% of their scripts filled. So we're looking for a binary outcome. Is this person likely to have them or not? Again, if we're trying to improve our clinical quality scores, focusing on folks who are the medium risk, who may not come in on their own, and we can identify a specific social barrier. Let's say it's transportation. They lack transportation, they live alone, or they live in a household without transportation. Just simply getting to that prescription might be difficult. So that allows us to understand, boy, we could probably improve their medication adherence rate if we were able to go ahead and have that script delivered to them through mail order, or arrange for them, if it's a controlled substance per se, to have transportation to the pharmacy. Then finally, we look at 30-day all-cause readmit rate. Now, I know there's at least 4 different ways in MIPS alone that this is being measured, whether it's in the general population or acute population or from skilled nursing facilities and so forth. Long story short, the measurement and the improvement of this is critical, not only to our patients, but to our operations and our financial success. So being able to understand, again, those at risk for being readmitted in the next 30 days and understanding why, so that we could really triage our clinical care coordinators with laser focus on these individuals to resolve any barrier that might be. That will allow us to make substantial gains, not only in their health, but our clinical quality measures and scores themselves, which, as we all know, could lead to tens of millions, if not more, in income for us, as well as brand recognition, while improving the healthcare outcomes of our patients. That's going to bring us to our next poll question. Do you use any form of health risk score based on non-clinical data? Our options are yes, we use health scores based on non-clinical data that is clinically validated, or yes, we use health risk scores based on non-clinical data, though not clinically validated. Another option, no, we are not leveraging health risk scores based on something other than the patient's clinical data. And then finally, we are not leveraging any health risk scores. Let's give us 30 seconds more to allow you to go ahead and read and respond to these questions, and then we'll look at our poll results. Okay, let's see what results we have. Overwhelmingly, we see that we are not leveraging any health scores. Just over 40% of you chose that bucket. And another third said we're not leveraging any health risk scores based on something other than the patient's clinical data. So it sounds like the concept of using a risk score is not foreign, but certainly the use of it on non-clinical data or any data at all is something that's still kind of a hazy forecast. We haven't really zeroed in the focus on that to see whether it would help our operations. Aaron, I'm going to let you tell a story about how those scores can provide additional insight to improve health outcomes.
Thanks, Rich. So I think this will be really beneficial since a lot of you aren't using scores anymore, and we want to illustrate how it can be used within some of your EHR systems or other population health systems to really help to zero in and improve those care outcomes. So since Rich pointed out that reducing readmissions impacts quality measures under MACRA and the Hospital Readmissions Reduction Program, we wanted to look at how predictive scores based on social determinants can be utilized in a workflow to prevent readmissions. In the scenario we'll look at, we have 4 male patients who are admitted to the hospital with heart failure. Traditional medical care would say they have the same risk because they have the same age, gender, and condition, and they treat them with the same care program. But studies show that statistically, at least one of these 4 gentlemen will wind up back in the hospital within 30 days. Looking at their social determinants can help explain why their risk is different. Within a hospital EMR or care management system, a readmission risk score could be presented to a care provider that predicts the likelihood of each patient to be readmitted to the hospital within 30 days of discharge based on that individual's social determinants of health. The scores shown here reflect the probability of each gentleman being readmitted between 0 and 100%, with 100% being the highest possible risk of readmission. So as you can see, of the four, Greg is the most likely at 71% to be readmitted to the hospital. Tony also has some social determinants challenges that raise his risk of being readmitted. What this illustrates is that with only age, gender, and medical data on individuals, we might be missing opportunities to intervene before a complication develops or worsens. Social determinants of health provide that view into otherwise hidden risks. Since Greg has the highest risk of readmission, the provider can start by drilling down into his risk score to see social determinant insights on why his risk is so high. These drivers of risk provide insights into the type of care that Greg will need in order to avoid ending up back in the hospital. For example, Greg has had a high amount of housing purchase activity. This is an indicator that Greg's been moving a lot. He likely doesn't have a stable place to recover from his hospital stay and may need access to housing. Where he's currently living has a high degree of crime in the neighborhood, so he might not be able to exercise or do recommended physical therapy outside. And he's also had unstable access to a phone, so he may be harder to contact for a follow-up appointment. These are all things that will make it harder for Greg to get well, and social determinants that healthcare organizations can address. Utilizing our insights, customers can partner with community resources or build programs in-house to address their needs. For Greg, that might mean connecting him with public housing options. But Greg wasn't the only one at risk. Even though he was at extremely high risk, we also want to look at Tony, who had a high risk of readmission. Insights into his social determinants reveal that he actually needs a different care plan than Greg. Tony's risk is tied to his estimated income, which means he may require some financial assistance. He may also need rides to follow-up appointments, since transportation access can be a challenge. And it looks like he has someone over the age of 80 living with him, which may be an indicator that he's providing care support. Asking Tony questions about his household situation could lead to getting him connected with a support group or finding alternative care for him and his elderly household member while he recuperates. You'll notice I mentioned asking Tony questions before determining the care plan is important. As we mentioned earlier, based on the ethical use of social determinants of health, social determinant indicators should always be used to trigger quality discussions with the patient, so the providers and patients can jointly determine a course of action that will work best for them. As a result of addressing the social determinants of health for patients like Greg and Tony, healthcare organizations can efficiently allocate their limited resources while reaping financial and reputational benefits. Hospital costs for readmissions exceed $41 billion a year in the U.S., so if even only 12% of those could be prevented, which was a very conservative estimate by one government agency, that's still nearly $5 billion a year in annual savings. Hospital systems could also save money by avoiding penalties for excessive readmission rates. It's estimated that hospitals that serve the most vulnerable patients would see a 22% reduction in penalties for readmission if social determinants are factored in. As this readmission prevention example demonstrates, the benefits to incorporating social determinants of health into workflows are extensive. Perhaps most importantly, providers are helping patients improve their health outcomes by more accurately surfacing the patients that need help and improving care and discharge planning by addressing social determinants as well as the individual's medical condition. By addressing these social determinants, providers can then minimize financial risk exposure in new care delivery and payment models and maximize performance incentive payments by more effectively treating patients. Also, by providing more personalized care, this can lead to better engaged patients and improve patient retention. For example, one study found that when healthcare organizations assist patients in accessing basic resources, 69% of those patients are more likely to recommend their clinic. Let's look at our last poll question. Has your organization committed resources to investigating and or implementing the integration of social determinants into your existing operations? Your options are yes, no, in the near future, or we haven't determined it yet. We'll give you a couple seconds to respond. Let's look at the results. So that's great to see. Your organization is committed, looks like 67% almost, to investigating or implementing those. About 17% in the near future and about 17% undetermined. But what I do find encouraging is no one said no, which is probably why you're on the call today. But That's great to see because this is becoming so critical to improving our overall healthcare system. So it is possible to help patients improve health outcomes throughout their journey. At the beginning, social determinants can act as an early warning system and risk stratification tool to prevent conditions from developing or worsening. Following an admission, social determinants can positively impact discharge planning and follow-up care to prevent readmissions. It can also be used to do predictive modeling and enhance medical research with the goal of improving care for current and future patients. So throughout the entire journey and all of the activities that are completed during care management, this can be an important asset to include and consider. And speaking of concluding, we are near the end of our time today, and I see we've got a number of questions, so I want to make sure that we get to those. But I did just want to recap that we've explored the benefits of social determinants of health and some of the challenges. We hope we've given you some important insights into the types of data that you should be utilizing and how you can integrate those into your workflows. The key that we really want to emphasize is that as great as data can be, it's only great if action is taken as a result. So we highly encourage the use of social determinants not only in predictive analytics to identify who is most at risk, but also to address the individual patient's socio needs. We believe social determinants can be a game changer, and we welcome continuing conversations with you on the topic. But for now, I'll turn it over to Lindsay to open up the questions.
Thank you so much, Erin and Rich. That was a great presentation. We will now move on to the Q&A portion of the webcast. Audience members can submit questions using the question tool to the left of their screen. So we do have a few, like about 9 minutes left here. We've got a lot of questions, so we will try to get it to as many as possible here. First question that came in during the presentation, how do you see pharmacists playing a role in the social determinant spectrum?
Yeah, so I just had the opportunity to meet with a number of pharmacy organizations over the last couple of days when we were discussing this. The role of the pharmacist is definitely growing in the overall patient journey, and they are seen as one of the key places that social determinants should be addressed because they probably have the most interactions with patients when they come in to pick up prescriptions on a regular basis. So a key area would be around improving medication adherence and looking at social determinants to decide, for example, should they spend more time doing consultations with certain patients that are at highest risk of not being adherent to their medications. But they are definitely an important part of the overall ecosystem of helping to address the patients.
You know, I'll add on to that, Erin. I know that pharmacies and prescription drug programs are heavily influenced by STARS, the 4 domains associated with that. And within one of them, there's a lot of focus on medication adherence as well as medication therapy management for a comprehensive medical review. So as we talked about earlier, trying to understand the people who would be motivated to participate in those and come on in, since everyone's already auto-enrolled. If you could identify those who might not come on in, but the barrier for them coming in could be improved from a clinical quality perspective, for how they're being evaluated and the performance. Again, that's an area where they can utilize social determinants of health to improve their quality scores as well.
Thank you. Next question, what determines the remaining 30% of overall health?
So I'll fire up on this one, and Erin, you could fill in. You know, so broadly, the buckets that we see are the social, economic, and behavioral, which we spent so much time on today. The other two are genetics, and then the quality of care that's being delivered to you.
Thanks. Next question. Is there a specific role for suppliers such as diagnostic device and pharmaceutical companies to leverage social determinants of health data?
So, Erin, I could jump on in and you can clarify if you like. Yeah, absolutely. What we're seeing is a two-party path for these types of companies. One, some of them are already partnered with particular health systems or health initiatives, for instance, choosing a city where they coordinate with other caregivers, with community engagement and community resources and so forth. And they're acting as almost kind of a central hub of information where they provide insight on their particular devices or their drugs in this particular case. And they bring in researchers to aggregate and collect data from all the different stakeholders, combine that with social determinants of health, and identify those who are at risk. And then that collaboration, you know, we talk about not just who's at risk, but the why. What is the health barrier? That that collaboration could then prioritize which health barriers can we collectively go ahead and address. Again, in urban areas, we've seen a tremendous success with this type of collaboration. The other area is that, if you are a device maker or a pharmaceutical company, let's take a pharmaceutical company as an example, you have a high degree of interest in making sure that their drug stays on formularies and that they prove the clinical effectiveness of this. So a pharmaceutical company that can collaborate with health systems to show not only, here is my drug and it's effective, the price is being delivered through the health insurer is effective as well, but I'm providing you additional insight as to, warning signs that, hey, look, these particular people might be at risk and that we might want to collaborate in order to go ahead and make this drug affordable or get this drug to their attention because they're lacking transportation. Providing that extra level of insight and attention allows them to be more sticky and provide additional insight as seen as a value add, simply for providing drugs or medical devices.
Great, thanks. Next question. How do you convince leadership that is focused on fee-for-service reimbursement to transition to a value and evidence-based model that is focused on long-term cost avoidance strategy?
Yeah, that's a great question, and one I think the overall U.S. healthcare system is struggling with as we're shifting to value-based care. I think the government is doing a lot to try and push that forward in terms of putting legislation in place that reimburses and also penalizes in a way that enforces switching over to value-based care. There's a number of studies out there that will show the value of addressing social determinants and how that reduces overall costs. So I think it's a combination of doing what's best for the patients and making sure that filters up to leadership, but also really zeroing in on the financial benefits of treating individuals holistically based on the studies and everything that are available to show that will have a big difference in reducing overall costs.
Great, thank you. Next question. How do you use the answers regarding the care drivers to turn this into a percentage of risk? Are points assigned to various response options, and are these points assigned based on the desired outcomes?
Yeah, so the care drivers that we mentioned are tied to the outcome that is desired. So it might be readmission, it might be medication adherence, or not readmission being a desired outcome, but preventing readmission. But really what we do is they're somewhat independent, where the risk is telling you who to target based on who has the highest risk based on an overall profile of their social determinants, like we mentioned before, looking at hundreds of different attributes, but then surfacing the ones that are having the highest impact so that if you address them, they would have the most chance of helping to prevent that readmission or improve that med adherence.
Okay, we have a couple more questions here. Again, if you do have any questions, please feel free to submit your questions using the question tools to the left of your screen. If we can't get to your question, both Rich and Erin have graciously offered to answer these questions individually after the webcast, so please feel free to submit your questions at any time. Next question that did come in, are you working with home health care EHRs to integrate this assessment in home health care comprehensive assessments in order for home care agencies to develop action plans?
That's a good question. We certainly are looking into it. I think that it could be integrated in any place where care management becomes a key concern.
Okay, next question. What role do you forecast for telehealth or digital health playing on the management side of social determinants of health success?
I think if you look at the examples we gave you with Bill and Larry, and specifically Larry, right, where he did not live near any health care provider, facility, or primary care physician, et cetera. And you highlight that Larry doesn't have much income and perhaps he's lacking transportation. I think identifying those social barriers, one of the first things you could utilize to overcome those problems is to leverage telehealth. So I think telehealth becomes if you want to call it a service that can be utilized to overcome health barriers.
Okay, thank you both so much. This concludes today's PatientEngagementHIT.com presentation. A special thanks to our speakers, Rich and Erin, our audience, and our sponsor, LexisNexis Risk Solutions Healthcare. Thank you and goodbye.